will get started, and there's some people still coming in. So thank you and a wonderful good morning again. Welcome to another installment of our CME program. Before we get started, I encourage you to all take a deep breath and just settle your mind before we begin today's meeting, bringing yourself to this present moment, giving thanks to God for the beauty of a new day and feeling grateful for our Bahama land. And in the words of Martin Luther King, if I cannot do great things, I can do small things in a great way. So welcome to our meeting and thank you for joining us. Today we have the Department of Medicine presenting to us, and this will be an M&M presentation. Our presenter is Dr. Tavanette Ingram. She is a registrar in the Department of Medicine and a candidate in the DM program in internal medicine. Her team and consultants are Dr. D. Seville and Dr. N. Munnings-Thompson. And so Dr. Ingram, you can take it away, and thank you for presenting to us today. If there are any questions, we can post them in the chat.
Good morning, everyone. Thank you, Dr. Black, for allowing the department to present on this platform. And as she said, today I will be presenting an M&M case that we had the privilege of managing on the ward. So today we're going to present TM, who's an 18-year-old female who currently resides in Lockdown, Luthra. So she had a past medical history of dysmenorrhea, currently on OCPs from 2016. Her last menstrual period was the 7th of March, 2020. And after delving a little on her gynae history, she said they come every 28 days, lasting about 5 to 7 days, and was only described as heavy. With regards to her social history, she denied any history of any alcohol or illicit drug use. So she actually presented with a one-day history of left lower limb pain and swelling, as well as chest pain. With regards to the left lower limb pain, it was described as a 10 out of 10 intensity at the level of the cough, with significant swelling as well as an increased warmth. Pain was exacerbated by movement. At about 2 p.m. on day of presentation, she also experienced some numbing sensation to the affected limb. With regards to the chest pain, however, it was described as central, but the intensity and character couldn't be delineated at the time. However, it was described as non-radiating, denied any pre or syncopal episodes and no shortness of breath. And by the time she reached to the accident and emergency department, the chest pain had already subsided. So she first presented to the clinic in Eleuthera at about 6:30 p.m. on the 15th of March. Vitals at that time, the temperature wasn't documented. However, we see that the patient was tachycardic at 117, respiratory rate of 18, and a blood pressure of 145 on 89, and an O2 sat of 99%. Again, there was no documentation if the patient was actually on oxygen or in fact, if the patient was on room air. So meds she received at that time was morphine, 10 milligrams IV with Gravol. She also received a normal saline bolus as well as a therapeutic dose of Clexane. So the point of care ultrasound was also done at that time, and it showed an absent color flow, non-compressible, and questioned if there was an intraluminal material, i.e. an acute thrombus, and suggestive of a left lower limb DVT at that time. She was subsequently referred to the accident emergency department at PMH. So triage vitals, she was afebrile at 97. She was still tachycardic at 125. However, at this time she had tachypnea at respiratory rate of 28, blood pressure at 125 on 81, and O2 sats was 98% as documented. The pertinent positive findings on examination, she had an extremity The left lower extremity was actually swollen, was warm to touch, but there was no evidence of any skin changes. And the assessment and plan at that time was to rule out a pulmonary embolism, a left lower DVT. Clexane was already given at the Eleuthera Clinic and for urgent CTPA with baseline labs. So the Timeless Medicine was able to see this patient. She was described as a young female sitting up in nil respiratory or painful distress. The mucous membranes were described as pink and moist, acyanotic, afebrile. Vitals at that time, she remained afebrile, still tachycardic at 128, but the respiratory rate had mildly improved and now at 20. The blood pressure was at 131 on 76, and the O2 sats was 99% on Romero. Cardiovascular-wise, it was specific for a pulse that was tachycardic, but no additional heart sounds, no murmurs. Respiratory abdomen, as well as CNS, was unremarkable. And again, we see where they describe a swelling of the left lower limb with an increased warmth. So investigations on presentation to the accident and emergency department with a psychosis of 18.5. With regards to differential, she had a neutrophilia of 87% with Vance of 3. She also had a microcytic hypochromic anemia. She came in at a 7.7, and she also had an element of thrombocytosis. With regards to her renal profile, the only mildly significant features was a mildly elevated potassium at 5.3 and mildly acidotic at 21. So the urinalysis as well as the chest x-ray was not suggestive of an infectious etiology. And the initial ECG had actually showed not only the patient had sinus tachycardia, but she also had a S1Q3 T3 pattern as evident on the ECG. So the CT pulmonary angiogram, so there was in fact a filling defect noted at the segmental branch of the left descending and subsegmental branch of the right descending pulmonary arteries, as well as which was suggestive of a pulmonary embolism. The visualized lung parenchyma appeared normal. There was no evidence of a pneumothorax or pleural or pericardial effusion. The visualized upper abdominal structures were unremarkable, and there was no evidence of any lytic or sclerotic bony lesions. So the assessment and plan at that time was an acute pulmonary embolus, a left lower limb deep vein thrombosis, already on anticoagulation therapy, and was now to be converted to therapeutic Clexane low molecular weight dosing for hypercoagulable workup. And with regards to her microcytic hyperchromic anemia, she was also for anemia workup. So the first day she actually presented to the ward, she was actually complaining of very severe pain to the left lower limb. Findings again was pertinent to the musculoskeletal. The left lower limb was very tense, painful, warm to touch, with no overlying skin changes. The femoral popliteal dorsalis pedis, however, was palpable, but when compared to the left, the volume was actually decreased. Vitals at that time, she remained afebrile. Tachycardia had somewhat improved, and now normal to 88, respiratory rate of 20, and the blood pressure of 114 on 80. The plan at that time was for an urgent Doppler ultrasound for vascular review to determine if the patient was a candidate for thrombectomy. For pain management and with regards to her PE, she was deemed hemodynamically unstable for an echo and to continue anticoagulation therapy at that time. So findings of the Doppler ultrasound. So it was significantly limited due to the patient's body habitus and significant edema. The common femoral, as well as the distal femoral segments actually showed a thrombus. The popliteal, however, and the other vessels were not visualized secondary to the body, a patient's body habitus as well as edema. And the impression at that time was positive for deep vein thrombosis of the left lower extremity. So Vascular was actually immediately consulted. The Doppler again was reviewed. And again, the main issue at that time was it was unable to determine if there was any proximal extension of this DVT. They then recommend a CT venogram for the patient to determine if there is any proximal involvement, and if there is in fact any proximal involvement, to reconsult. So summary of the labs throughout her hospital course. So her leukocytosis with vandemia had actually resolved without initiation of any antibiotics. She actually had worsening of her anemia and actually required the transfusion of at least 3 to 4 units of packed red blood cells during her hospital course. Also significant is her worsening of her thrombocytosis, but here we see that she was also very iron deficient, and most likely the cause for her thrombocytosis. So with regards to her renal function, she was actually within normal limits when compared to her admitting labs. So other features of her anemia workup was unremarkable, as well as her initial investigations with regards to her hypercoagulable workup was also non-reactive. So the gynae service was also consulted, mainly to acquire alternatives in light of history of an abnormal uterine bleeding. They too agreed that the oral contraception should actually be discontinued and suggest an intrauterine device to follow up as an outpatient. They also made note of the patient's worsening anemia to query cause, and this was most likely not due to any PV bleeding. So other cause of her worsening anemia was actually discussed at the team level. Also, to make note that the patient actually was complaining of a history of constipation and actually required stool softness, which goes against the fact that she may very well not have any bleeding along the GI tract, because of the fact that blood in the GI tract can actually be a cathartic. So again, the hypercoagulable workup was discussed in many instances at the team level. Here we see that the main pathophysiology behind your RVTEs is the fact that there may be an element of blood flow stasis, there may be an element of endothelial injury. And with regards to hypercoagulability, there's also an inherited versus an acquired component. So we actually did and go through all of these possibilities, but the main issue with regards to our patient was the fact that based on her BMI, she was considered obese, as well as an acquired hypercoagulable possibility because of the chronic use of OCPs. So our first initial screen and actually came back as needing financial clearance, and for further questioning and asking at the total cost, it was actually totaled up to $2,500 in order to get a full workup for her inherited as well as acquired hypercoagulable possibilities. So the CT venogram was not able to be obtained until 1 week later. So the findings for this was actually suggested that there was a filling defect in the inferior vena cava at the level of L3 vertebrae, with extension into the left iliac, internal iliac, external iliac, as well as the common femoral popliteal, as well as the peroneal anterior, as well as the posterior tibial veins. This filling defect is actually causing almost a complete occlusion of the IVC and a complete occlusion of the left lower limb veins from the bifurcation to the distal aspect. The left lower limb is also enlarged when compared to the right, secondary to edema and skin thickening. There was significant subcutaneous edema as well as fat stranding at the left lateral lower abdomen and the entire left lower limb. The left lower musculature appeared very bulky in comparison to the right, which is suggestive of inflammation. There was also a hypodensity noted within the lateral aspect of the left gluteus medius muscle and between the left lateral abdominal muscles, in keeping with fat stranding and edema. There was also free fluid in the left suprapatellar region, but there was no evidence of any fracture or dislocation. So the impression at that time was the fact that the patient had an extensive deep vein thrombosis involving the distal IVC from the level of L3 with complete occlusion of the entire left lower limb venous system. And despite no obvious compression by the right common iliac artery, May-Thurner syndrome may be a differential. There was also an enlarged left lower limb with subcutaneous edema, fat stranding, as well as a left suprapatellar effusion, as well as a left lateral abdominal wall, as well as left gluteal muscle edema and fat stranding. So again, Vascular was actually reconsulted and the patient was then optimized for OT for IVC filter placement plus or minus thrombectomy. So surgical report summary. So a Cook IVC Select filter was actually deployed at the L2 vertebrae with fluoroscopy guidance. And thereafter, the left groin was isolated. The femoral sheath was sharply dissected. The sheath open and the saphenofemoral junction, as well as the femoral veins, were isolated. Systemic heparin was then administered. The vessels were then clamped and venotomy was made. And a large volume of an organized thrombus was removed from the iliac vessels with a retrograde application of a number 6 Fogarty catheter. So the entire hospital course actually took up about 22 days. Her discharge meds was inclusive of your DOAC, your factor 10 inhibitors, your rivaroxaban, i.e. Xarelto, as well as she was sent home on iron supplements and to follow up with the different specialties, i.e. general medicine, vascular, as well as gynae. So what are the bottom line and action plan? So at a department level, when we discussed this case, it was found out that there were a number of modifiable risk factors that we actually didn't cater to, in particular to this case presentation. So the European Society of Cardiology actually stratifies these risk factors, whether it be weak, whether it be as a result of bed rest for more than 3 days, other comorbidities that increase risk factors for VTE, whether it be diabetes mellitus, arterial hypertension. And here we see that obesity as well as pregnancy is a number one, even though it's a weak risk factors for patients for VTE. Moderate risk factors include patients with systemic diseases, whether it be your autoimmune or your inflammatory diseases. And here we see that the use of oral contraceptive therapy actually follows, is under the moderate risk factors for patients with VTE. And some strong risk factors includes a history of a fracture of the lower limb, as well as hospitalization, whether it be for heart failure or atrial fibrillation, history of hip or knee replacement, a major trauma, a myocardial infarction, especially if it's within the last 3 months, a previous VTE, as well as any history of a spinal cord injury. So because of the discussion at the department level, I wanted to highlight some of the statistics because some of the modifiable risk factors may not have very well been targeted with respect to this patient. Actually, what I found in the Caribbean, the Bahamas, that actually has the highest obesity rate with a 31.6% of the population filling this category, where the 38.1% of women and 24.4% of men are actually considered obese within the Bahamas. It was actually Poitier and its colleagues that actually suggested the Bahamas actually face issues with undernutrition throughout history as a result, be it as a result of agricultural industry being affected by a number of adverse climate events, as a result of heavy reliance on food imports from other countries, or as a result of globalization, trade policies, and the growth of multinational food companies that have actually impacted the Bahamian food landscape. So there was also a qualitative study done in the Bahamas where it showed the impact of a sustained health policy and the population level interventions on reducing the prevalence of obesity. This actually showed that the Bahamian national reports show a consistent increase in the prevalence of obesity in adults between 1989 and 2012. It also showed that there was, however, a decrease in the adult prevalence rates between 2012 and 2019. There is, however, a gendered health disparity where we see a prevalence rate continues to rise among women up to 2019, but have a decrease in men between 2012 and 2019. The years listed actually represent the times when data were available from reports of Bahamian national surveys. So here is an obesity treatment pyramid that was provided by or developed by Angela Fitch, where we suggest that we take a multidisciplinary approach based on a patient's BMI. Here we see that there's also, we can provide a multi-component and intensive behavioral interventions, prescriptive nutritional interventions, pharmacotherapy, but these are patients suggested for patients who have a BMI of greater than 30 or BMI of greater than 27 with comorbidities. There's also recommendations for endoscopic procedures as well as patients for surgery based on their BMI and comorbidities as well. So recently, with the treatment in patients with severe obesity, there was actually a trial which compared DOACs with warfarin in a patients with a BMI of greater than 40. And the total number of patients in this study was total of 2,321. And they actually recommend that patients with a BMI of up to 40 milligrams per meter squared and a weight of up to 120 kilograms, that all DOACs are actually very reasonable. However, for patients with a BMI of greater than 40 kilograms per meter squared or kilogram or greater than 120, they actually recommend that only your factor 10 inhibitors are actually reasonable, which includes your rivaroxaban as well as your apixaban. So the European guidelines, most recently up to 2020, they actually provides us with an estimated risk for long-term recurrence, whether it be low risk, whether as a result of minor surgeries, immobility for greater up to 3 days or more due to an acute illness, trauma with fractures, where there is a high possibility or estimated risk for long-term recurrence of RVTEs of greater than 8% per year in patients with an active malignancy, one or more previous episodes of VTE in the absence of a major transient or reversible factor, and if a patient was deemed to have antiphospholipid antibody syndrome. However, I wanted to highlight patients who are intermediate risk of about 3 to 8% per year. And these were described as patients with minor surgery, again, and hospital admissions of less than 3 days with an acute illness, and patients who are in fact on OCP therapies, whether the patient is pregnant or peripartum, or any leg injury without fracture associated with a reduced mobility of more than 3 days and a long haul flight. So there was actually systemic review and meta-analysis that actually looked at the risk of recurrence in men with women, my apologies, in women with venous thromboembolism as it relates to an estrogen-containing contraceptives. They actually suggested that the risk of VTE reoccurrence in women with estrogen-containing contraceptives appears to be low, which supports the short-term anticoagulation for 3 to 6 months after VTE related to an estrogen-containing contraceptives. However, much more data and contributing risk factors for the specific patient population is actually limited, and a strong recommendations about duration of anticoagulants cannot be made. There was actually a large prospective study on VTE reoccurrences and risk factors for reoccurrence are actually needed in patients with VTE associated with the estrogen-containing contraceptives who actually stop anticoagulation after a 6-month period. So there were a number of institutional limitations when taking consideration this case that we presented today. There were a number of delays with regards to imaging, and I just wanted to highlight what is actually standard of care in these patients which actually present with extensive VTEs. So by definition, iliofemoral DVT is anything that have an acute onset of a thrombus of less than 21 days with severe symptoms from an increased DVT burden, such as edema, paresthesias, pain, claudication, and ulceration, and if there's a failure of conservative therapy with anticoagulation alone. With regards to the diagnosis, there are recent advances in the utilization of the ultrasound as well as CT MRI scan, as well as endovascular procedures that have resulted in an increase in the detection rates of our IBC venous thrombosis. The ultrasound actually provides an accurate, non-invasive method of diagnosing IBC thrombosis and is often the first-line investigative modality. However, the main limiting factor with regards to the ultrasound is the fact that it's operator dependent and can be very limited in patients with an increased body habitus. So the contrast venogram actually remains the historical standard for the diagnosis of IBC thrombosis, with a very low false positive rate, with the advantage of access for immediate intervention and treatment. There's local thrombolysis IVC filters, angioplasty, as well as stenting that can be performed concurrently. However, this is a very invasive modality, and it's actually associated with a 2 to 10% incidence of post-procedural DVT. So other modalities include your CT. This too is also a rapid imaging, non-invasive, and can accurately diagnose and assess the extent of a thrombus in the presence of an associated abdominal as well as pelvic abnormalities. However, the MRI is actually replacing the CT as the optimal non-invasive imaging tool, because of the fact that it avoids radiation and provides a more accurate delineation of thrombus, including the proximal as well as distal extent, as well as its age, as well as if there's any concomitant IVC abnormality. However, the main disadvantages for this modality is the fact that it's high in cost, its accessibility, and there also remains a risk of a nephrogenic systemic fibrosis, especially in your gadolinium-based contrast agents, especially in patients who have a concomitant renal impairment. So other issues that we actually faced in the management of this patient was the number of pharmacy shortages. Here we see that, like we see before, that the patient was severely iron deficient and required, in addition to blood transfusions, she also required Benefit, but unfortunately it was not currently available in our pharmacy at that time. There was also an issue of procuring blood products. It's not unique to our setting. Actually, it's an international issue, especially as a result of this most recent pandemic and the causing an even worsening of the worldwide shortages with regards to procurement of blood products. And finally, we had an issue with regards to financial clearance, even though the patient was admitted when requesting for a hypercoagulable workup. So I just wanted to highlight some of the recent updates by the American Society of Hematology. In 2020, they actually provided guidelines for the management of VTE, whether it be deep vein thrombosis or pulmonary embolisms. And patients with an uncomplicated DVT, they actually suggest you offer home treatment over hospital treatment, but you have to take your patient in consideration and see if they actually require hospitalization, whether as a result of a limb-threatening DVT or if there's a high risk for bleeding. or for those who are requiring IV analgesics that may actually benefit from initial treatment in hospital. And for patients with pulmonary embolism with a low risk of complications, they also suggest home treatment over hospital treatment. However, even though these prediction scores are made available to us and have a very high predict patient outcomes, we should never replace them with our clinical judgment. Made available to us is the Pulmonary Embolism Severity Index, or as well as the simplified PESI, which have been widely validated, but these recommendations does not apply to patients what other conditions that actually require hospitalizations, have limited or no support at home, and cannot afford medications or have a history of poor adherence, especially in patients with a submassive or massive PE at a high risk of bleeding, and those requiring IV analgesics. They actually recommend that these patients should benefit from hospital admissions. So for patients with DVT or PE, the ASH actually recommends the use of your direct oral anticoagulants over your vitamin K antagonist. However, you have to take in consideration again your comorbidities of your patients, whether they have renal insufficiency, or if there's a element of moderate or severe liver disease, or the patient have antiphospholipid syndrome. To this date, patients with moderate to severe liver disease and antiphospholipid syndrome, vitamin K antagonist is still gold therapy. However, recent data actually suggests in patients with renal insufficiency, you can now use your your factor 10 inhibitor, specifically your apixaban, and this can actually be reduced to about a 2.5 milligrams twice a day for these subset of patients, but should be used with caution. So for patients with DVT and PE, so they do not suggest one DOAC over the other. And for patients with proximal DVT, they actually suggest that anticoagulation therapy alone over thrombolytic therapy, in addition to anticoagulation, especially in patients where the thrombolysis is a reasonable to consider for patients with a limb-threatening DVT, and for patients with who are younger and at low risk for bleeding with a systemic DVT involving the iliac, as well as the common femoral veins. And in patients with a PE who presents in a with hemodynamic instability, they actually recommend thrombolytic therapy, but however, we should take in consideration the absolute as well as the relative contraindications before providing patients with this treatment. And for patients with PE and echo findings, as well as an elevated biomarkers that's compatible with a right ventricular dysfunction, but without hemodynamic compromise, they actually suggest that patients should be treated with anticoagulation alone over the routine use of thrombolytic therapy. And for patients with an extensive DVT and home thrombolysis is considered appropriate, they actually suggest the use of a catheter-directed thrombolysis over systemic thrombolysis. This was actually given a very low certainty evidence, and the panel actually followed the grade ASH rules and issued a conditional recommendation. So they also provide guidance for patients who had a previous DVT or PE and was already on vitamin K antagonist and represents with another VTE. So patient, especially if a patient was previously on your vitamin K antagonist, they actually recommend the use of your low molecular weight heparin over your DOACs. And for patients with recurrent unprovoked DVT or PE, they actually recommend an indefinite antithrombotic therapy over stopping anticoagulation after completion of primary treatment after a 6-month period. Also, specifically in patients who have a cardiovascular risk and on antiplatelet therapy, they suggest that you suspend aspirin while continuing anticoagulation. increased risk of bleeding. They also suggest that for patients with DVT with or without an increased risk of post-thrombotic syndrome, they actually suggest the routine use of compression stockings, but this was actually a conditional recommendation due to the fact that the majority of patients may actually not benefit from the use of stockings to reduce the risk of your post-thrombotic syndromes. However, the stockings may very well help to reduce edema as well as the pain associated with the acute DVT in selected patients. So there is a continued debate with regards to the duration of therapy for our venous thromboembolisms. In a recent conference at the American College of Physicians, Dr. Mall had actually recommended that we go back to basics and see what the difference between and determine the difference between superficial as well as deep veins with regards to the upper limb, and the difference between the distal versus proximal veins with regards to the lower limb, because this will actually guide us on who should be treated and how long they should be treated with anticoagulation therapy. So this algorithm was actually taken from the American College of Chest Physicians. Here we see they suggest the duration of therapy for patients with a proximal DVT or PE. If it's provoked, they actually suggest a 3-month therapy of anticoagulation therapy. However, if it's unprovoked and a patient has a low bleeding risk, they actually recommend an extended therapy, and in some instances recommend up to 12 months of treatment of anticoagulation therapy. If a patient has a moderate bleeding risk, they also recommend an extended therapy. However, if a patient has an unprovoked proximal DVT or PE and has a high bleeding risk, they recommend a 3-month treatment with anticoagulation. So for patients with an isolated distal DVT, and patients who present with mild symptoms or a high bleeding risk, they actually recommend a serial imaging of every 2 weeks. And if there's an extension of this thrombus, they actually recommend at that time that the patient should be anticoagulated. However, in patients who present with an isolated distal DVT and presents with severe symptoms or risk of extension, they suggest that you anticoagulate initially. There's also recommendations for patients who present with VT associated with non-benign lesions, whether it be solid or hematologic. Previously, they actually recommend that these subset of patients get the lower molecular weight heparin, but now recent studies have actually now recommend that these patients are in fact candidates for the newer anticoagulation agents. And in patients with an upper extremity DVT, they too again suggest that we anticoagulate. So I just wanted, the last 2 slides, I just wanted to highlight who should be tested, and in fact when these patients should be worked up for a hypercoagulable state. Here we see that any patient who presents with an idiopathic or recurrent venous thromboembolism, any patient who presents with a first episode of VTE at a very young age, especially for patients who less than 40 years of age, a family history of a VTE, especially in patients who particularly in patients who have a first degree relative who presents with an extensive VTE, a venous thrombosis in an unusual vascular territory, inclusive of your cerebral, hepatic, mesenteric, as well as your renal veins. And if a patient presents with warfarin-induced skin necrosis, they actually suggest then when 2 or more of these thrombosis characteristics are present, that the prevalence of your antithrombin, protein C, as well as your protein S deficiency, as well as your factor V Leiden are actually increased. And with regards to when should we actually work up these patients and for the hypercoagulable state, they actually recommend that the patients on DOACs, as well as your vitamin K antagonists, should not be tested until at least 4 to 6 weeks after discontinuation of the anticoagulants because of the fact that they often interfere with the clot-based chromogenic coagulation assays, and it may actually lead to inaccurate results and may render the test uninterpretable. And there's also compelling reason to perform these tests with great caution. And if it must be done, you must take great caution and should avoid acting on any false results. So that is the end of my presentation. These were my references. Any questions or recommendations?
Thank you very much, Dr. Ingram, for a really excellent presentation. And thank you for highlighting not just the patient's risk factors, modifiable risk factors, but the modifiable areas in our own processes of management. Dr. Dia-Seville, the consultant, is also on the chat, and I see we have a raised hand. So we'll let Dr. Dia-Seville go on with his comments, and then Dr. Frankson, you can unmute and you can make your comments and ask your question.
Hello, good morning, everyone. First of all, I would like to thank you, Dr. Block, for inviting us to do this CME presentation of our case. We thought that it was an interesting case to bring forward, just based on the fact that, this was a young patient. She had a common diagnosis that we encounter in medicine. She did, in fact, have modifiable risk factors, as you pointed out, to why she would have developed this DVT. And she also had a very interesting course in terms of the extension of her DVT that was able to be confirmed on the venogram, and it required surgical intervention. So it was a dual approach to providing optimal care for her. And I think it was a good opportunity to outline what the literature says in terms of how we treat these patients, and how it is best to optimize these patients moving forward in terms of treatment, and also modifying the risk factors that are present in our particular case to hopefully prevent another DVT from happening again. Thank you, Dr. Ingram, for an excellent presentation as well in preparing it. And thank you all who were able to join us today.
Thank you, Dr. Seville. And Dr. Frankson, you can go ahead with your comments and question.
Thank you, everyone. Thank you, Dr. Ingram, Dr. Seville. Really enjoyed that presentation. Could you remind me, I may have missed it, what is the difference in morbidity and mortality for those who are treated in these recommended ways versus the older approaches?
So, okay, so what are the morbidity and mortality? So previously, we have been treating these subset of patients with your vitamin K antagonists. And like we know, there are a number of limitations with regards to these agents, where continued monitoring of our INRs and increased risk of bleeding, especially. It's so unpredictable, could be influenced by the particular agent, whether it be generic or but generic formulation, whether it be what they eat, and their increased risk of bleeding. And hence the reason why a number of studies have actually now suggested the use of the newer agents because of their decreased risk decreased risk of bleeding associated with them.
Forgive me for interrupting you, but the question is really just looking for a number. What is the difference in mortality and morbidity that the studies have reported?
So the exact number I can't say. but I'll look up that right now.
Yes, I can comment on the exact figures as well, Dr. Frankson. What I can say is, in terms of the mortality in patients who are untreated, who have VTE, of course, is going to be much more increased compared to somebody who receives that treatment. So now the difference in mortality between the various options of the DOAC or the vitamin K antagonists, essentially the studies show that there really is not one that is more superior than the other. However, there is a difference in terms of just how these patients may actually develop symptoms of bleeding, depending on the particular case, and different things that can contribute, for instance, to increased risk of bleeding. There seems to be a little more increase in bleeding in terms of certain patients who receive DOAC versus vitamin K and vice versa. So you have to take a patient specific approach and trying to evaluate which one will respond or likely have less complications than the other. In terms of the morbidity, patients who are untreated for VTE, particularly a DVT, these patients will definitely go on to develop post-thrombotic syndrome, and that can have an increased morbidity in terms of affecting ambulation and all of the sequelae that can happen as a result of that. Venous stenotic ulcers from chronic venous insufficiency, venous intermittent claudication, and so forth. And of course, for PE, when these patients are not anticoagulated, these patients run the risk of developing chronic thrombopulmonary hypertension. So these patients can develop subsequently right-sided heart failure, which can drastically impact their functionality, making them, in worst cases, oxygen dependent and requiring long-term treatment and management of right-sided heart failure symptoms.
So the differences that you're sure of are in quality of life.
Yes.
What you are doing is to encourage us to do a local study to answer that question that I posed.
Right. Absolutely. I think that would target our specific population, and it will also help in, just finding out what our population best improves the outcome of our local data here. Yes.
Thank you very much.
Thank you very much. Presentation from Dr. Raquel Davis. And so we have a question from Dr. Sinqui. Thanks for the presentation on this important and too common and vexing problem. Can you mention the benefits of the use of filters you found in research on the topic? And then after that, Dr. Smith, you can go ahead with your comments and question.
Hi, good morning, Dr. Swinky. I unfortunately can't comment on the filters aspect of it. I think the person that would probably be able to provide much more information on that in terms of, which one is better than the other, a vascular surgeon. I'm not quite sure about the answer to that question. Apologies for not having that information this morning.
I am not sure that I see a vascular surgeon on the call, but if you are here, please feel free to weigh in. And in the meantime, Dr. Smith, you can go ahead with your question.
Dr. Black,
Yes, go ahead, Dr. Sinqui.
can I make a comment? So,
Of course.
having recently dealt with a patient with DVT and PE and wondering about the use of filters, when I looked it up, looked like there's a big shift away from filters. And I would invite everybody to just take a look back at the benefits for filters and the complications and risk in inserting the filters if it is of no benefit. That is the only comment I'd like to make. The vascular surgeons, I think we can ask their opinion and probably share it at a later date. Thank you.
Thank you, Dr. Sinqui. Dr.
Thank you.
Smith, you can go ahead.
Pleasant good morning. And again, Dr. Ingram, thanks for a very good presentation. Dr. Seville, thanks for your guidance with that. So what I was impressed with as a part of the presentation is ideally, or most times when we're doing studies. So I do thank you for bringing up the comment of the Pixaban or the new anticoagulation therapy in comparison to Coumadin or warfarin. And it is just the caveat that I want to throw out there. In keeping with the comment that Dr. Seville was making before when they talked about newer anticoagulation therapy versus vitamin K antagonists, and then it wasn't really a mortality that they talked about, but morbidity in terms of the biggest thing in terms of bleeding. I think that one of the studies that was done that could be seen on the British websites was that they actually took patients of different subsets of patients, and they actually put in patients that would generally not be included in a lot of the studies, i.e. the creatinine that was greater than 1.1, the patient that was greater than the age of 80. And in that, I think that the biggest thing is that there was a reduction of bleeding and a reduction of poor outcomes in those patients with the Pixaban or with new anticoagulation therapies as opposed to the vitamin K. So I think it is something that is well said, that is well brought forward. Just the very last caveat with it is, remember, there are not a whole lot of guidelines that speak to people with end-stage renal disease. They speak to people of chronic kidney disease, predominantly with a GFR that is greater than 30 and not less than that. So we must be very careful when we are using it in that patient subset. Thank you for a very good presentation, and that was just my thought.
Thank you very much, everyone. So it's nearing 9 o'clock, so we're coming to the end of our meeting. And if there are any further questions, you can reach out to the presenters. And if we get any further information from the vascular surgeons, we'll be sure to share it along. And so thank you for joining us today. And remember, the feedback link is the same feedback link that we always use. And in the notice for the meeting, you do have the feedback link, and you also have the code, the CME code, which is Life Learner. We have applied for CME points for this meeting. And so once the points become available, you will be notified from the website. So please remember to do the feedback. We look forward to seeing you again on the last Friday of the month, which is the 26th, Friday, the 26th of May at 8 a.m. for another installment of our CME program. Thank you, everyone, and have a great day.
Good morning, and thank you again, Dr. Black, and thank you everybody who was able to make it.